Yeah, we all know that intra-arterial BP measurement is the only method which provides true arterial BP values, but this clearly is not feasible or for most of the time. So there are many other ways in which this can be done, and the most popular is the mercury manometer, which was first described in 1896 by Scipione Rivarocci, and it has remained in virtually the same format for 125 years. And that is quite remarkable. There are hardly any medical instruments which have remained in the same format for so long. There's the aneroid BP monitor and the electronic BP monitors, which have now more or less replaced the mercury manometer. And then we have out-of-office BP measurements, which can be done with the earlier ones instrument I showed, as well as these. However, the finger monitors are often inaccurate, not recommended. The wrist monitors also are not validated. And then we come to the ambulatory BP monitoring, and which has a cuff and attached to a small device which will inflate and deflate and measure the blood pressure at very regular intervals, usually every half an hour or so. And so if we look at the recommendations, this is the latest 2023 European Society of Hypertension. Office blood pressure is recommended for diagnosis of hypertension because it is the one method by which hypertension-related risk, benefits of antihypertensive treatment, and treatment-related BP thresholds and goals are based. So that means all the trials and all the endpoints are based on office measurements. So one can't disregard that, and that always remains the cornerstone of measurement and therapy of hypertension. However, you can notice, of course, that's a class 1 recommendation, and a second class 1 recommendation is out-of-office BP is a source of multiple BP-related information before and during treatment. It is therefore recommended to obtain additional information on BP values by ambulatory BP monitoring or home BP monitoring, or both if available. So both are class 1 recommendations and should be followed. BP measurement. Now studies have identified 29 potential sources of inaccuracies related to the patient, the device, the procedure, and the observer. So before we start analyzing, we need to make sure that the data that we get is correct. Just 2 days ago in the OPD, my resident checked the blood pressure and said the BP is 106/70. And I was skeptical, and then I noticed that the cuff was improperly placed and the repeat recording was 160/100. So you can get huge differences if you don't do the measurement properly. And Mark Twain is supposed to have said, data is like garbage. You'd better know what you are going to do with it before you collect it. And it can truly be garbage if you don't do it properly. And these are some more monitors called the finger monitors. That's the ring. And these also are not being validated. I think they're going to be important in future, but currently I don't think they should be used. And this is what the guidelines say. If you look at the lower box, cuffless BP devices should not be used for the evaluation or management of hypertension in clinical practice. Automatic, electronic, not the mercury, upper arm, not wrist, devices are recommended for office and out of office BP measurements, home and ambulatory, again a class 1 recommendation. So first and foremost is what I want to know is my blood pressure data accurate, especially when it's done not by a professional and done at home. So this has been brought out by another speaker. If you garbage in is garbage out. And we know that there are so many different various areas where one can go wrong, and this has been mentioned earlier, so I'm not going to dwell on this. But there are some points which are often overlooked, and I would like to dwell on that. First of all, where is the position of the manometer? Here you can see that the manometer is at roughly the patient's chest level. That's an aneroid machine which is sitting on the mattress or on the chair where it's being recorded. And here you have at a much higher level, this is in an ICU setting, this is in an outpatient setting, and we can see that the manometer is at a much higher level. So how many of you here think that this is correct? Can I just see by a show of hands? Or is this correct? Where the manometer is at, again, a show of hands. So, actually there's a lot of misinformation here. The manometer position is not important. It has to be at the operator's eye level to avoid parallax error. It is the cuff which has to be at the patient's heart level and not the manometer. Of course, this is now becoming increasingly irrelevant with the digital or the electronic devices, but the cuff is still important. Here, where should the position of the tubes be? It is here, in this case, extremely medial, lateral, and here over the brachial artery. So again, quickly show of hands, over the brachial artery, wrong. So, so every cuff has a rubber bladder inside it, and you can see the bladders from here to here. It's not the entire length. The middle of the bladder should overlie the brachial artery, not the tubings. The manufacturers have intentionally put the tubings in an eccentric position so that you can put your stethoscope there easily. And yet, we insist on putting it wrongly and somehow squeezing our stethoscope underneath that. And I can tell you that 99% of my residents also get it wrong. So this is how it should be. I'm just showing a few because it's not really stressed upon. And the tubing can be coming up from the top also. It really doesn't matter. And this is how it is done for ambulatory BP monitoring. So now, which instrument? Clearly the mercury has been replaced by the oscillometric. Now, I used to think that the oscillometric machines used to have a sensor which is listening to the Korotkov sounds. At least some more than a decade ago I used to think, but that's not how it works. What they are measuring is the oscillation inside the cuff. There's a sensor for that. The maximum oscillation corresponds to the mean blood pressure, and then the systolic and diastolic are then derived from that using a proprietary algorithm which is different for each company. And therefore, unlike a mercury instrument, you cannot say that all electronic instruments are the same. They need to be validated and calibrated, and very few of them are. Among the ones available in India, I find that Omron seems to be the best. I have personally tested so many of them. I have no shares in that company, just want to make that clear. So let's see the value of ambulatory BP monitoring. It gives you multiple BP readings in conditions that reflect the usual environment, including daily activities and sleep. Otherwise, it's just a 10-second snapshot of your blood pressure, not 10 seconds per day. 10 seconds in 3 months, that's on an average when a patient comes to you, and you want to extrapolate that. So the more, obviously the more readings you have, the more accurate will be your treatment and diagnosis. So it has a better prediction of hypertension-mediated organ damage than office blood pressure, and more accurate prediction of outcome and mortality than the office blood pressure. So the value of ambulatory BP monitoring is that it gives you 24-hour BP variability and morning BP surge, which otherwise is often missed. And more importantly, it tells you about the dipping, which is the magnitude of the nocturnal BP change, which can predict events better than daytime BP. So these are the various patterns that you can get. This is the reverse dipper. That means at night, it goes up instead of coming down. This is the one where there is a dip but not sufficient magnitude, and this is the normal, the dipper is normal, and then you have extreme dipper. So they have different patterns, and patients who do not have the dipping have a much worse outcome. Here it is the, on the y-axis you have the cardiovascular events, and you can see it's much highest among reverse dippers and then the non-dippers, and dippers and extreme dippers have the lowest rate of outcomes. What about nighttime versus daytime? Look at the one in black is the night blood pressure, and that is far more important than the daytime blood pressure, and that is the one pressure that we are not measuring. We are measuring daytime pressure, and that too in the office, and even at home we are not doing it. And this is just office versus 24-hour average systolic. Now mind you, this is average systolic, not nighttime. Look at the office blood pressure and the risk. It's almost flat, whereas the ambulatory monitoring shows a much steeper curve in 3 different studies, the systolic hypertension in Europe, Dublin and Pamela studies. You can see that the 24-hour systolic blood pressure has a much better predictive value. Again, it's above the age of 50, it is systolic blood pressure, which is far more indicative of risk than the diastolic. And this is again a very common misconception that diastolic is more important. So there are limitations. They are often performed by inaccurate devices, and there is a lack of nighttime BP evaluation when you're doing home monitoring. And ambulatory BP monitoring also, it's expensive and causes discomfort in some and not widely available. And one has to understand that as of now, there are no outcome-based randomized controlled trials to compare ambulatory BP monitoring with office BP monitoring. Indications, I think I'll skip. So these are finally the guideline on how to diagnose and therefore to take treatment forward when you're using out-of-office blood pressure recordings. And if you're using the target, now we heard from the previous speaker, the targets also may vary, but let's assume that it is 140/90. If it is 140, then the home BP would be less than, anyway, more than 135/85 is considered hypertension. This is for the diagnosis of hypertension. The 24-hour mean is 130/80, and the awake mean 135, asleep mean 120/70. This all sounds a little confusing. This is the easy way to remember it. Whatever your blood pressure in office is, 5 less than that is what is recommended for home BP monitoring. Now, if you're using ambulatory BP monitoring and if your threshold is 140/90, the 24-hour would be 10 less, 130/80. And the most important is the night time, which is 120/70. It's just 10 less, and that's probably the easiest way to remember that. So I'm going to conclude that there are numerous potential sources of inaccuracy, so you should make sure that the data you get is accurate, and all these 3 modalities of BP measurement are complementary to each other and not competing with each other. The guidelines clearly support collection of out-of-office data, but there are some unanswered questions, and basically that means we need outcome-based randomized control trials. So how do I use it? Home blood pressure monitoring in virtually every patient. I tell all my patients to check it. Of course, it has some downsides. Some people overreact to it and get frightened. I keep telling them that they need to be more frightened of high BP than of low BP. One low BP reading and they come down on their medicines. This is especially useful in white coat, elderly and orthostatic symptoms. Ambulatory BP monitoring I use to confirm hypertension before treatment and to assess control, and most importantly for dippers, especially when you find that there is target organ damage and you find that the BP when you're checking is fairly controlled. So there is a discordance between the BP that you get and hypertension mediated organ damage. That would be a perfect indication for doing ambulatory BP monitoring and also home BP monitoring.